Sir John Monash public lecture series provides Monash University Malaysia an opportunity to engage with the community in Malaysia and the region through the promotion of thought leadership in key areas, especially of strategic importance and development in this region over the 21st century. This lecture series takes inspiration from Sir John Monash, who is considered to be one of Australia's most distinguished citizen, scholar, leader, and a man who sought to use his education and abilities for the benefit of the community. The public lecture series covers a wide variety of contemporary and interdisciplinary topics that will be presented by high-profile thinkers, international leaders, policymakers, corporate leaders, and leading scholars who are distinguished in their areas of expertise and whose work has made a significant impact to the global community. Before I get our today's speaker to take on, I would like to make a few comments about our current speaker today. You know, Professor Steve Nicholls graduated from the University of Adelaide in 1994, completed his physician training in the Royal Australian College of Physicians, and then did his PhD in medical biochemistry in the University of Adelaide. Subsequently, he did his postdoctoral work in various parts of Australia, and then went on to work in Cleveland Clinic between 2004 and 2006, and worked there as a researcher until 2012. And when he came back home to South Australia and joined the South Australian Health and Medical Research Institute as a heart health team leader, and then a deputy director, as well as a professor of cardiology at the University of Adelaide. In 2018, he joined Monash University as a professor of cardiology and the director of cardiology, as well as the director of the Victorian Heart Hospital. Professor Nicholls has won several awards and honors, and they are too numerous to list here, so I would not try to do that. He's also been involved in a large number of important and highly influential clinical trials. Professor Nicholls has been a recipient of over $100 million of research funding over the period of his academic career. He has more than 360 peer-reviewed publications, nearly 30 book chapters, abstracts, and invited lectures run into the hundreds. And again, I will not take time to list any of them here. Professor Nicholls' research interests focuses on the role of metabolic risk factors and imaging in atherosclerosis, with work spanning from early discovery to leadership of large clinical trials. He's the chair of Australian Atherosclerosis Society Clinical Council, Australia and New Zealand Alliance for Cardiovascular Trials, Asia Pacific Cardiometabolic Consortium, Secretary of the Cardiac Society of Australia and New Zealand, and a Fellow of the Australian Academy of Health and Medical Sciences. He has now taken on the job as a director of Victorian Heart Hospital, which is the first specialized cardiac hospital in Australia and is being built in Clayton with funding from the Victorian government and Monash University. Can I get you to join me in warmly welcoming Professor Stephen Nicholls to deliver his lecture.
Okay, you ready? Okay.
Thank you. Good evening. Can you hear me at the back?
I think it's
not on. Are we on? We're not on. Is that better? Is that better? That's better. Okay. Good evening, and thank you for the kind introduction and invitation to talk to you tonight. And what I'd like to do in the next hour is kind of give you a little bit of a cook's tour of heart disease. And I'm going to put it in the context of 4 patients. And we're going to walk through what we kind of know about a range of forms of heart disease and talk about the progress that we have made and the progress that we need to make. Now, when I had a look at previous Sir John Monash lectures, and the titles of those talks, I got the sense that it really was about thinking big and asking kind of broader questions that really do have a global kind of relevance. And so I put a title here, which I think is an achievable title, but it's a title that really will need the entire community, government and researchers, the medical community, in addition to patients, to be able to realise. But hopefully I can make an argument for you that there are many ways in which we can do that. So first of all, we should start with Sir John Monash, and we've already heard he is an extraordinary individual in the history of particularly the state of Victoria, but has an important impact on Australia being a military leader during World War I, which really was Australia's first seminal episode as a young country, really having to kind of stand on its own 2 feet and led the army gallantly on the Western Front, came back to Victoria and was really able to kind of integrate a range of his skill sets to leave an extraordinary impact on the community. And ironically, Sir John Monash dies of the complications of heart disease at the age of 66. My link to John Monash is that John Monash, having been from Melbourne originally, his family moved to a small town in lower New South Wales called Jerilderie when he was a teenager. He was quickly realised by the teachers in the school that he was intellectually quite advanced, and the family was sent back to Melbourne to invest in his education. My mother's family are actually from the same town, so the likelihood is that several generations ago very well could have been in that class with John Monash, although not quite as advanced from an intellectual perspective. So what's going to happen in the next hour? And here are the realities of what the world will face. 2,000 people will have a heart attack around the world. 500 people will have a sudden death. And at least 500 of those people will have that event having had no prior warning symptoms. And that is a concerning fact, that a quarter of people's first presentation of heart disease is either dying or having a very significant cardiac event. And what is becoming increasingly important is that heart disease is no longer a disease of affluence. It doesn't matter how old you are, it doesn't matter what gender you are, it doesn't matter what your ethnicity is, it doesn't matter what your education is. Heart disease is now a global challenge that spreads across all barriers. Now, I'm going to start by telling you some good news and then some sobering news that comes after that. From a Western nation's perspective, things were actually starting to look a little bit better. We knew a lot about how to prevent the disease. We had better treatments for the disease. And what we saw was that in affluent countries, over a period of time, we saw that mortality rates due to coronary heart disease actually appeared to decline. That's the good news. The bad news is that we now have a mortality rate for heart disease that's about the same as cancer. So we've done a lot better, but we're still in a bad place. And if you look at it from a global perspective, the very sobering reality is that we actually see this rise in mortality rates due to coronary heart disease in particular globally. And that is largely due to the fact that obesity has become a global pandemic. Right? So we have seen now obesity and its metabolic complications, in particular early type 2 diabetes, appear in every part of the world. And we've seen it accelerate, particularly in the developing world. And that is going to drive a whole range of risk factors, and it's ultimately going to result in a much higher rate of premature and aggressive heart disease. And that's exactly what we're seeing in our hospitals around the world now. It doesn't matter what country and what part of those countries you're in. We're seeing coronary disease in particular in countries that we'd never seen it before. And there's a cost that comes along with that. It's not just a cost in terms of the morbidity and the mortality that happens to those individuals. There's a social cost and there's an economic cost. And in most countries of the world now, cardiovascular disease is the leading drain on public healthcare expenditure, particularly in the developed world. So there's a lot of it, and it's costing a lot of money, and it has enormous implications beyond those simple facts. Now, I want to tell the story about 4 patients. I'm going to talk about a young Indigenous girl with rheumatic heart disease. I'm going to talk about an overweight man who has a heart attack. I'm going to talk about an older gentleman who has heart failure, and I'm going to talk about an older woman who has atrial fibrillation, the most common heart rhythm disturbance in the world, and give you a bit of a sense for what we know about each of those conditions and what we're doing to try and either treat or prevent each of them. So let's start with rheumatic heart disease. Rheumatic heart disease fundamentally occurs following a streptococcal infection. It's a group A strep. Often individuals have either a sore throat or they have skin sores, and an antibody reaction following that infection, which is suboptimally treated, can cross-react with tissue in the heart. And while it can affect the heart muscle and it can affect the sac that lies around the heart, from a cardiologist's perspective, the most common problem we see, and the thing that causes me the most concern, is it has a predilection for the cardiac valves. So you see there up on the upper right-hand corner on the left, you see what the normal valves look like. The tissue kind of opens and closes. They're the doors between the pumping and the filling chambers of the heart. They enable for the blood to go in the right direction. And on the right, you see what we see with rheumatic heart disease. Those valves become thickened, they don't open, and they don't close properly. And so over a period of time, individuals with rheumatic heart disease will and have the potential to develop progressive forms of narrowing and leakiness of those valves. And it really is a global disease. And it's not only a global disease, but it is a global disease of social disadvantage. This gives you some sort of sense for the rates of rheumatic heart disease around the world. The lowest rates are in the developed world, and everywhere else the colours change. And what's really important to notice, that rheumatic heart disease, or RHD, can be controlled through improving living conditions, reducing overcrowding, getting better access to healthcare, and importantly, appropriate antibiotic treatment for those early streptococcal infections. And so when you add all of those things up, I think that kind of tends to explain why we're more likely to see rheumatic heart disease be a major problem in more developing kind of populations. Now, this is the Australian experience. We have a national registry for rheumatic fever and rheumatic heart disease. 89% of Australians in that registry are Indigenous Australians. 61% were female, and 41% are aged between the age of 5 and 14. So in my country, this is exactly the demonstration of what I've just shown you. It exemplifies that this is a disease of the socially disadvantaged. And so it's about how do we get better access to healthcare to basically prevent what should be a preventable condition. So why is this important? Because ultimately, affecting that valve function, potentially affecting the heart muscle function directly, is going to have a range of complications. These individuals are going to develop progressive heart failure, i.e. another inability for their heart to pump the blood effectively to the rest of the body. They're at a risk of developing heart rhythm abnormalities, stroke. Women with rheumatic heart disease are at a much higher risk of complications during pregnancy. These individuals are at a higher risk of recurrent episodes of rheumatic fever because they're going to go back into those overcrowded kind of areas where they're going to still be at risks of recurrent infection, recurrent rheumatic fever, and ultimately that's going to result in a higher risk of premature death. So what can we do for rheumatic heart disease? Apart from preventing by looking at overcrowding, we can treat those streptococcal infections early. We can give regular antibiotics long term to individuals who we think are at a greater risk of rheumatic fever. We can regularly monitor those valves, and we can do that either by actually listening to the chest, but we can also use cardiac ultrasound, and cardiac ultrasound has evolved from something which is a console about this big to something that I can now essentially do on my iPhone. So that is going to make going out into remote areas much easier than it was before. And then it may be that for a number of those individuals, they're going to need a treatment for their valve at some point. It might be that we just need to stretch that narrowed, thickened valve open by blowing a balloon up in the middle of it. You kind of see an example of that on the slide. It may be that these individuals need an operation to either repair or replace the valve. And what is very exciting in our field is that there's been a whole host of advances in our ability now to treat valve disease on the tip of a catheter. To place a catheter up and to either replace or repair valves on a catheter without having a big cut in your chest and being in hospital for 7 days with a high risk of surgical complications. And it will be, as those technologies advance more and more, it will provide an important additional way to be able to treat these individuals. So in our country and in many countries around the world, there really is an important call to action in terms of what we do about rheumatic heart disease. So if you kind of go through this, it really highlights our approach that goes from prevention at the top all the way through to treatment at the bottom. And it really does call on us both as individuals and communities all the way through to governments and policy on how we can kind of battle this. For those individuals who have either been exposed to strep A or have an active infection, early access to antibiotics is critical. For those who have rheumatic fever without necessarily having the valve abnormalities, active treatment, potentially a vaccine, and there is a lot of interest in developing vaccines, early and recurrent monitoring of these individuals, all the way through to then kind of more advanced treatments at the higher end for those who have then developed fairly significant kind of valvular disease who require intervention of one form or another. So that's the rheumatic heart disease story. Now, what about heart attacks? In Australia, one Australian has a heart attack every 12 minutes. 55,000 Australians have a heart attack a year. And it is probably the most common individual cause of death in our country. And they're largely caused by a build-up of plaques. These are kind of growths that develop in the wall of the blood vessels. They will cause, if they're in the blood vessels that supply oxygen and nutrients to the heart, blockage of that can cause a heart attack. If it's going to the blood vessels to the brain, blockage can cause a stroke. If it goes to the vessels that take blood to the legs, then it can cause problems with an insufficiency of blood supply to the feet, and so individuals may end up having either an amputation. So depending on where those blockages kind of build up, can have fairly profound consequences. And we know that those plaques don't just start overnight. We now know that this is a progressive disease that starts in all of the arteries of the body at a young age and slowly grows over the course of decades. We understand a lot about the pathology and the factors that are involved in that growth of plaque. And we ultimately know that while there are many plaques in the body, one may cause a heart attack. And we understand that the fundamental differences between those plaques that will cause a heart attack and those that won't cause a heart attack. And those that are going to cause a heart attack are more likely to contain cholesterol, they're more likely to contain inflammation, and those are the plaques which we think are hot plaques that are more likely to rupture and cause a clinical event and cause a patient to come to hospital. Now, to kind of re-emphasise that concept that this actually starts early, this is the experience from the United States where we're able to put ultrasounds within the blood vessels of individuals after they'd had a heart transplant. So if you think through transplantation, very unhealthy hearts are replaced with somebody else's healthy heart. And that is typically, in most countries, individuals who've had a motor vehicle accident, who are otherwise healthy, they're pronounced brain dead, and their allegedly healthy heart is able to be transplanted into another individual. And so at the Cleveland Clinic, we were able to do ultrasounds within those hearts a few weeks after they were transplanted as a baseline to kind of see what happened to the blood vessels afterwards. And what we were able to identify was that if the donors were under the age of 20, 1 in 6 of those donors already had evidence of plaques in the arteries. And you can see here as the age of the donor goes up across the slide, the likelihood that we would find plaques in those normal healthy arteries substantially increased. So this is not a disease that starts when somebody has their heart attack in their 5th or 6th or 7th decade of life. It is there early. And that is critical because it gives us important opportunities to be able to prevent the disease at an early stage. And if prevention is, and it should be, the most important thing we do to eradicate heart disease, then starting early is going to have the greatest impact across a population. Now, what have we learned and who has taught us those lessons along the way? The first is that cholesterol is important. This is Nicholls. He's a young medical student in St. Petersburg, Russia, who in the early 20th century performed a fairly simple experiment. He took some rabbits, he fed them lots of cholesterol, and then he looked at the aortas, the main artery of those rabbits, and he did a histology and he looked down the microscope, and that's what he drew. And what he drew was the very first observation of what we call the cholesterol-laden foam cell. These are the main cells of plaques, and they're full of cholesterol, and it was the first elegant demonstration that simply feeding a lot of cholesterol ends up with a lot of plaque in the arteries. The second important observation was by James Herrick, and this was published in the Journal of the American Medical Association, again in the early part of the 20th century. And what he and his colleagues were able to report was that in individuals who'd had heart attacks or had sudden death, which was presumed due to heart disease, that they were able to identify that there was likely to be fresh blood clot blocking off the artery. And so cholesterol driving atherosclerosis is important, and blood clots seem to be important in terms of the context of that kind of acute clinical event that those individuals had. And then we kind of forward a few decades when heart disease from a Western perspective was getting out of control. We saw high rates of heart disease following World War II, and a number of countries were trying to understand what was driving that so that they could try and do something about it. The United States made an important investment. They wanted to do a large clinical registry to understand the factors that underscored the progression and the natural history of a disease. And in the first instance, they were going to do neurological disease. And a lot of pressure was put on the National Institutes of Health to kind of say, well, actually, most Americans are dying from heart disease. That's actually what we should be doing. And so at relatively late notice, the whole project was changed to a focus on cardiovascular disease. And what they did was they took a whole bunch of individuals who lived in a town called Framingham, Massachusetts, and they studied these individuals, and in fact they've studied their children and their grandchildren, and they measured a whole bunch of clinical factors, and then they were able to follow these individuals for many years. And the Framingham Heart Study really has given us important insights into what were the factors, the major factors that associate with the likelihood, or a greater likelihood, that you'll have a heart attack. And at the same time, there was increasing recognition of the health effects of smoking. And by the time the Surgeon General's report into the relationship of smoking and health came to be published and released, it was pretty clear that smoking was established as being a causative factor not only in lung disease but also in heart disease. And so those two kind of seminal moments together really were able to kind of lead us to this situation where we could identify a number of factors that we knew were associated with a greater risk of heart attack and a greater risk of stroke. That included diabetes, high blood pressure, high cholesterol, smoking. We knew it ran in families, obesity, high triglycerides, which is one of the other fats in the blood, a low level of HDL, which is the good form of cholesterol. If you didn't have enough of it, it wasn't going to protect you. And each of those factors by themselves, but in particular when they were combined, were going to identify individuals who were at a higher risk of having a subsequent heart attack. And so they would identify the individuals who we should be more aggressive with regards to the way that we tried to reduce that risk. And then what we've continued to try and do is identify additional factors. And I'd already kind of given you some insight into the fact that it was those inflamed plaques, the hot plaques, that are more likely to crack and cause a heart attack. And what we've learned in the last generation, the last 20 years in particular, has been that in a lot of ways atherosclerosis, those build-up of plaques, is an inflammatory process. We know that the same cells that fight infection in the body can go into the walls of those blood vessels. It gets out of control and it really just fires up a whole process. And that's important because it potentially gives us new targets to go after. Once we've lowered cholesterol and lowered blood pressure, maybe we go after trying to target inflammation. And that's exactly where the field kind of lies today. Now, I talked about family history being important, and there's been a big search for, is there a gene that causes heart attacks? The answer is no. There's lots. Every week I open a journal, there's another gene. And some of those genes that are associated with the risk of a heart attack are associated with specific things, higher cholesterol, inflammation, for example. But you can see on the right, there's a whole host of genetic abnormalities which associate with a higher risk of heart disease, but don't seem to have a mechanism, at least today, that explains that. Now, this is really complicated because there are lots of genetic defects, and each of them are actually low in terms of their prevalence. And so how do we try and put that all together? And that has been something that the field has struggled for many years, until we kind of asked a fairly simple question. Well, what if we combine all the genetic defects together? So rather than thinking about heart disease being a single gene condition, what if we think of somebody's risk putting all the genes together and calculating what we call a polygenic risk? And so there are a number of groups now around the world who have done that. They've been able to do an entire genome-wide scan. They've been able to find each of those fairly uncommon mutations in an individual, and they can calculate a score. And we've been able to demonstrate that those individuals at the very highest levels of polygenic risk have a particularly high risk of having a heart attack. Now, on the right is a really provocative finding, and that is that if you separate individuals in either low, medium, or high polygenic risk, the individuals with the higher risk are much more likely to have a clinical event. The bars are higher on the right than they are on the left. But even within that group with the higher risk, those individuals who actually adopted a healthier lifestyle, better diet, better exercise, had a lower risk of having a heart attack. And that's really important because it tells me that your genes do not seal your fate. Your genes suggest that you might be at a higher risk, but it can be modified. It can be modified by doing the right things, whether that's lifestyle, whether that's with new therapies, and we're starting to see very similar kind of observations. Now, there are other factors that we're increasingly recognising are associated with a greater risk of heart disease. Now, I don't put this up there to frighten anybody to learn the molecular pathways of atherosclerosis, but it's really to make the point that we're increasingly recognising that pollution, whether it's air pollution, whether it's noise pollution, can have a significant impact on cardiovascular risk, whether it's through eliciting psychosocial stress, whether it's by driving specific molecular pathways in the walls of those blood vessels. We know that a range of forms of pollution are going to be associated with a greater likelihood of obesity, inflammation, high blood pressure, diabetes, and the build-up of those plaques in the walls of those blood vessels. And ultimately that is going to, and we've seen, it does associate with a greater risk of heart disease. It has implications for how we develop policy around prevention. As I said, there are links between stress, depression and heart disease. Here you see that those individuals with evidence of psychosocial stress not only are at a higher risk of having high blood pressure, but that actually translates to higher risks of heart attacks and strokes that are not accounted for simply by the blood pressure. So there's a lot of work that's undergoing at the moment to try and understand what are the links between stress and heart disease beyond looking at those conventional factors. And putting all of that together, we're seeing the typical heart patient evolve from the 50s, when it was kind of a leaner smoker, to now when it's the globally overweight and obese individual. And that's going to create an important problem for us, because as childhood obesity has become a pandemic, that is going to translate to a huge wave of premature heart disease. And so while we used to see people present with their first heart attack in their 50s, 60s and 70s, we will now start seeing people present in their 30s and 40s. And it was simply because we did not adopt the preventive things we needed to do at an earlier age. Now, we are what we eat. We know that is going to drive the risk factors I've already talked about. But what else do we know about what we eat? Well, it's complicated. If you read every newspaper, half of them will tell you that fat's important, half of them will tell you sugar's important, and we fight a lot about that. My patients come and say, should I eat less fat or less sugar? I said, I think you should just eat less. I think it's pretty clear now that sugar and carbohydrates are clearly a factor associated with cardiometabolic disease. Fat's a lot more complicated because there are different types of fats. And we know that the saturated fats and the trans fats are going to associate with risk. The polyunsaturated fats, we think, are not. And that translates to positive findings from clinical trials that we see. This is a really important study from Spain, where individuals at a high risk for heart disease were randomised to either a normal diet or two forms of a Mediterranean diet, one with lots of nuts, one with lots of extra virgin olive oil. And you can see that the two curves for the Mediterranean diet are quite separate from the control diet. And the individuals who were given a Mediterranean diet were 37% less likely to have a heart attack or die during follow-up. So clearly there's something about that diet which is important. We know it's high in polyunsaturated fats. It's high in a number of other kind of constituents as well. But the type of fat you eat is clearly going to be important. What is a reasonable amount of exercise? When I see my patients and tell them they need to exercise, they go a whiter shade of pale. They think I'm thinking they need to go run a marathon. The American Heart Association recommends that you have at least 30 minutes of moderate intensity aerobic activity at least 5 days per week. Now that's walking your dog. It's not dawdling like this, but it's not running a marathon. Now you can do at least 25 minutes a day of vigorous aerobic activity for at least 3 days and some high intensity exercise. So the bottom line of that slide is it's really about doing an amount of exercise that just gets the heart rate going a little bit, just gets you sweating a little bit. And I tell my patients that what I really want you to do is 30 minutes a day. And you actually don't even have to do all 30 minutes at one time. People are busy. So say split it up into 3 lots of 10 if you want, but you've got to do enough to get a little bit of a sweat, get the heart rate going. If you're just going to drift along and smell the flowers, that doesn't quite count. Smoking cessation is the single most important preventable factor for heart disease. Smoking causes heart disease, and we know that if you stop smoking today, your risk for heart disease will not come back to normal, but it will actually plummet, and it will plummet very quickly. And here you see some data from the United States. Within a fairly short period of time, you see a nearly 50% reduction in the risk of having a heart attack by simply stopping smoking. It may not necessarily get rid of the plaques that have built up in the arteries, but it will make the blood less sticky. It will make it less likely to clot. It will make those arteries less likely to rupture because those plaques will be less inflamed. So smoking cessation, we know smoking is a big problem, and we know that smoking cessation can clearly have a major impact. Now, we do have beyond medications, beyond lifestyle, a range of medications, and we know that these therapies work because we've performed large clinical trials. And by doing those clinical trials, we've been able to show that doing something is better for a patient than not doing it, i.e. they're less likely to come into hospital, they're less likely to die on long-term follow-up. And the two take-home messages in terms of medications and how they work, one, if you're having a heart attack and you're sitting there with that blood clot that's blocked the artery, we know that getting rid of that blood clot is important for you. Blood thinners, whether we open the artery up with a stent, have all been shown to reduce the chance of a bad outcome for patients who are having a heart attack. And then if you kind of look at longer term management beyond thinning the blood, treating those risk factors reduces the risk of heart attacks in the highest risk patients. So it's lowering cholesterol, lowering blood pressure, lowering blood sugar in patients with diabetes. And now we're starting to see evidence that even treating inflammation. We had a provocative result from a clinical trial reported at a major meeting 2 weeks ago showing that an affordable anti-inflammatory agent could actually lower the long-term risk of heart attack and stroke in a large clinical trial. Now, my problem is every time I do a clinical trial and we show a new medication works, my patients say, so you want me to take another medication? I'm already taking 5, now you want me to take 6 and then 7, and you can imagine that patients don't necessarily want to do that. So there's a lot of interest in can we combine medications into a polypill? Can we combine cholesterol-lowering medications with blood pressure medications? That has the potential to improve adherence with those medications. There's a cost saving, and it may be important in particular in developing nations of the world. Here's just one example of individuals who were randomised to either get the polypill or usual care. The patients who had the polypill had better reduction in blood pressure and cholesterol by combining them all into one pill. And so there's a lot of interest in how we can make that a much kind of more widespread kind of therapy that we use for our patients. This slide is just here really to remind me that we need new medications. So this looks at all of the trials that we did of statins. Statins lower cholesterol, and in every one of the trials that we did, they were shown to reduce the likelihood that you would have a heart attack or that you would die. But if you have a look in green, you'll notice that in every single one of those trials, the green bar is bigger than the orange bar. So the best benefit we had in any one of those trials was what we called a 45% reduction in risk. And that was a good result. But what it also told me was that 55% of the heart attacks that were going to occur still occurred. And it tells me that these therapies alone for many patients will not be all that we need to reduce their risk. And so we need to develop new drugs that go after new targets. It's why scientific research and drug development continues to be important and critically needed in this space. What about cardiac rehabilitation? Can we put all of that together and actually try and help people put programs together where we're going to focus on all of the things we've talked about. And there's evidence that individuals who go to those rehabilitation sessions are more likely to be compliant with their medications. Their risk factor control is going to be better. And we think that will ultimately translate to being less likely to have a subsequent heart attack. And then finally, from a therapeutic perspective, is there going to be a vaccine for all of this? We can now give injections that lower cholesterol, and there is one coming that we'll be able to give an injection 2 times a year. But again, there's a lot of work that's being done to see can we develop a vaccine that might target one of those other factors that causes heart disease. Again, there's work being done in that space. And it complements a number of important parallel initiatives which have already been shown to make a major difference for patients with heart attacks. So the thing that we did in the last 100 years that made the single biggest difference for somebody having a heart attack and their ability to live was to simply establish a coronary care unit in a hospital. So rather than put those patients just in a normal ward somewhere down the end where nobody's really paying that much attention to them, we would put them in a highly monitored situation and we would monitor their heart rhythm. And so if they had an abnormal heart rhythm, we could apply a treatment very quickly. And that very rapidly made a major difference in the outcome for patients who are having heart attacks. We were able to start looking at the arteries, and we were able to do that because of the work of a number of important individuals. This is Werner Forsman, who won the Nobel Prize for essentially developing catheter-based delivery to the heart. In fact, the very first time he did that on a human, he did it to himself. But he did it with the idea of being able to measure the pressures in the heart, potentially being able to deliver medications to the heart, and he, with some colleagues, won a Nobel Prize many years later. But it was the work of Mason Soanes at the Cleveland Clinic who was able to demonstrate that, in fact, you could actually inject dye down those blood vessels. And by doing that, you were essentially able to look for narrowings. The coronary angiogram was born. It was the late 1950s. We thought at the time that it was dangerous to inject anything down those blood vessels. And in fact, on the right is the very first angiogram that Mason Soanes did, and it was an accident. He didn't mean to inject the dye down there at all. And as he turned around to resuscitate the patient, in fact, he realised the patient was actually talking to him. The patient survived, and that was really the birth of modern day kind of angiography. And why that's been important is it's been able to identify patients with blockages, and we've been able to do things for those individuals to treat those blockages. First of all, we're able to do bypass operations. We're able to take veins from the leg and ultimately arteries from elsewhere in the body to basically develop a bypass around those blockages. And then over the course of the last 40 years, we've been able to use a range of techniques with a catheter to be able to stretch a lot of those blockages open with a balloon and put a stent in those arteries. And that's become kind of commonplace therapy now for many patients with kind of high-grade blockages. And then finally, from a heart attack perspective, we get to this point of being able to deal with somebody having a cardiac arrest. And the idea that if we teach enough people CPR, if we have enough public access to cardiac defibrillators, then we give somebody the absolute best chance of not only surviving a cardiac arrest, but having a good kind of neurological outcome by being able, as quickly as possible, to be able to restore blood flow to the brain. Now, I'm going to quickly talk about the last two kind of areas in a much kind of briefer kind of way. The first is atrial fibrillation. Now, on the left, you see the normal heart, and the normal heart has normal electrical pathways. The normal pathway starts up here in the filling chambers and kind of goes down a pathway to the pumping chambers so the blood can flow into those chambers and be pumped out. And you see what's essentially a normal heartbeat here on the left. On the right, you can see that the heartbeat doesn't look the same. It doesn't look regular, and these little kind of bumps here have all disappeared. And you see when you look at the electrical activity in these filling chambers, it's really quite disordered. And that's a condition we call atrial fibrillation. It's the most common heart rhythm disorder. It is much more common as you become older. So 1 in 25 Americans have atrial fibrillation at the age of 60. By the time you're 80, it's 1 in 10. There are a number of causes of atrial fibrillation: heart disease, high blood pressure, thyroid disease. You can get acute atrial fibrillation if you drink too much one night, and we certainly kind of see individuals with holiday heart syndrome. And it's important for us because we know that individuals with atrial fibrillation are much more likely to be in hospital. They're at a high risk of stroke, heart failure, heart attack, dementia, and premature death. It's common, it becomes more common. We are an ageing population. We are going to see a lot more of this, and it has bad outcomes. So what can we do? We can use drugs to either slow the heart rate down if it goes too fast. We use drugs to try and put somebody back into a normal rhythm. We can try and get them back into a normal rhythm by using the paddles like you see on the TV. Or we can use a range of other approaches, either operations or, again, catheter-based techniques to try and treat those kind of pathways to either disrupt them or disrupt the source. And that's increasingly being used. But what we've also seen is that if you take all of those risk factors that I've talked about, whether it's obesity, high blood pressure, sleep apnea, smoking, whatever, and you aggressively treat those risk factors, individuals are much less likely to have a recurrence of those rhythm disturbances. And so it tells us that all of those risk factors that I've just shown you that are important for plaques and aggressively treating to try and prevent a heart attack are similarly critical in terms of their ability to prevent having the most common rhythm abnormality that we see in the world, which is associated with significant morbidity and mortality. And then finally we get to heart failure, the idea that the heart just can't get the blood to where it needs to go. And there are really two forms of heart failure. There's a form of heart failure where the heart's enlarged. This is a normal heart in the middle. The heart's enlarged, it's floppy, it's simply not particularly good at pumping the blood. And on the right, you've actually got what looks like a normal size heart. And the problem is not pumping, it's just it's stiff. So it just doesn't expand enough to let enough of the blood in to be able to pump it out. And that's going to have consequences in terms of congestion, and blood and fluid's going to build up in the lungs, and individuals are going to become quite short of breath and fatigued, and ultimately they end up in hospital. We know again that that becomes more common with age. You can see, it doesn't matter whether you're a man or a woman, in the individuals in their 60s and over the age of 75 are going to be much more likely to have heart failure with age. Admissions to hospital are an enormous problem. There are more than 1 million admissions each year for heart failure in the United States and Europe. It is responsible for up to 4% of hospital admissions. So about 1 in 25 admissions to hospital for anything are for heart failure. Up to 9 out of those 10 admissions are not patients with new heart failure. They're patients who have already been diagnosed as having heart failure. And the average patient stays in hospital 5 to 10 days. And it's the facts on the right which are the really sobering facts, which is almost 1 out of 4 hospital patients with heart failure are re-hospitalised for heart failure within 30 days. And if you look at 60 days, it's nearly 50%. So once you have it, you're just going to have this endless cycle of coming in and out of hospital. And it creates an enormous challenge. We know it's not only associated with a higher rate of death, but that its contribution to an increase in death rate from heart disease is much greater than other forms of heart disease. But that comes with an extraordinary cost to healthcare systems and society. So this is US data from this year. In the United States, they're projecting that nearly $40 billion will be spent on heart failure. More than 50% of it is on the hospitalisations. So there are enormous efforts are underway to try and work out how can we move these patients out of hospital where they don't want to be and make this a much more preventable, manageable condition in the community. We have a number of drugs that we can use. We can use diuretics to reduce the congestion of blood in the lungs. We have a number of agents that can offload the heart and make the heart's work easier, and they've been shown to be beneficial for patients. And there's a lot of interest in asking the question, well, are there medications that might just make the heart beat better? And that's actually been a much trickier situation. We haven't really been able to demonstrate that they work in clinical trials. We have a range of devices. We have pacemakers and defibrillators that we can implant that improve outcomes for individuals with heart failure. We have kind of portable artificial hearts that can be used from a temporary perspective for individuals who have the most advanced forms of heart failure, particularly those who are on the waiting list for a transplant, and then ultimately for a very small number of individuals with advanced forms of heart failure, they are lucky that there's a donor. We have now, 2017 was the 50th anniversary of Christian Barnard's first heart transplant in South Africa. Worldwide, we do about 4,500 transplants a year. We have way more than 4,500 individuals who are on a waiting list at any one point in time. So organ donation from a societal perspective continues to be a critical issue. And then the final question we ask ourselves with regards to damaged hearts and heart failures is, can we regenerate heart muscle? Can we inject stem cells, and will they grow new heart muscle cells? Now, they do on the lab bench. We just haven't been able to translate that yet into a really effective approach to treating heart failure in the clinic. But I think that's something that's likely to happen over the next 10 to 15 years. Now, before I kind of finish with a few just parting comments and a little bit about the heart hospital, I just wanted to make one really important point. Heart disease is equally a problem in women as it is in men. There is a notion around the world that heart disease is a problem for men. Women don't get heart disease, they die of breast cancer. In my country, women are 3 times more likely to die of heart disease than breast cancer. And that is consistent across the world. Women typically present a little bit older. They are less likely to receive the investigations for heart disease than a man is for the same symptoms. When their heart disease is being diagnosed, they are less likely to receive proven medications than men are. And that will ultimately translate to worse outcomes. So putting that all together, we need better research into what drives heart disease in women, and we need better public communication programs to women to seek attention when they get symptoms, and to the medical community to be able to investigate and treat them appropriately. So what do we need moving forward? First of all, there are a range of public health challenges. We need to tackle the obesity epidemic to a much greater degree. We need to make it easier for individuals to access healthier food options. It is far too easy to access less healthy food options. There is considerable debate about things like a sugar tax, for example, and that is going to gain increasing attention in many countries. There is an ongoing need to continue to target smoking, and that is going to require government legislation to do that, whether it's increasing taxes, whether it's plain packaging, whether it's reducing and restricting access. Governments need to take responsibility if we're going to have any kind of advantage there. We need to have a greater emphasis on the importance of passive smoking and to restrict access to smoking in public places. And then finally, governments are going to have to recognise what they're starting to recognise, which is e-cigarettes and vaping are not safe. And we are now starting to see reports on a daily basis of the health concerns that come along with vaping. And then finally, there needs to be a greater promotion of healthy lifestyles and, importantly, recognition of risk in the community so individuals can take responsibility for their own risk of heart disease. People need to know their numbers. They need to know what their cholesterol is. They need to know if they have diabetes, and they need to know what their blood pressure is. And every adult should have that done at least in their 20s. And they need to take responsibility in terms of knowing what that is. We need to promote the need that if individuals get chest pain, they need to call an ambulance. They don't sit at home for 8 hours. If you have chest pain and you're having a heart attack, time is important. And the quicker you get to hospital, the quicker you receive life-saving medications. We need more community access to defibrillators. And we start to see that in more public places. And then finally, everybody should know CPR. If you want a driver's license, you should be able to demonstrate that you can do CPR. If you want to graduate high school, you should have been taught how to do CPR. Because you don't know, but one day you may save somebody's life by doing that. We need inexpensive and accessible drugs for those that are most likely to benefit from their use. And we have a massive equity problem in the world. Those individuals who need it the most often have the least access to these drugs. They need to be made cheap and they need to be made accessible. We need to develop new drugs. But we need to do that providing a regulatory framework that facilitates bringing safe and effective drugs to the clinic quickly. It doesn't help people if it takes 20 years to bring a new drug to the clinic, and it doesn't help if the costs of those new drugs make them completely out of the affordable range for countries, nevertheless individuals. So we need better ways to develop drugs that will then mean that they will come to the market in a much more cost-effective approach. We need to continue to develop safe and accessible, minimally invasive procedures. I truly believe that in 20 years' time, very few individuals will have major cardiac surgery. Almost all forms of cardiac disease that need some sort of aggressive treatment will probably be applied on the tip of a catheter, and surgery will be reserved for a small number of highly complex forms of heart disease. We need to take the management of patients to where the patients are. So this is a really elegant trial that was performed in the United States where they managed blood pressure in African American men by going to where the African American men were. They tend to meet at barbershops. So they took the pharmacist to the barbershop. Right? And they measured their blood pressure and they explained what the importance of blood pressure was, and they explained the importance of taking blood pressure medications. And you know what? The patients who had their blood pressure treated in the barbershops, they had better blood pressure control. And it's a great example of going to a community and identify what's the barbershop for that community. Take the management of the disease to the patient, because it's a patient-centric approach to the way that we're going to treat risk. How are we going to take all these new technologies that are appearing, whether it's digital devices, artificial intelligence, whatever, and how can we enhance the way that not only we do our research, but how importantly can it change the way that we treat our patients or reduce the risk of heart disease in the community? We've got so much to learn in terms of how we can apply these technologies far more effectively. They can tell us a lot. What do we do with that information, and how does that improve the outcomes for individuals remains an enormous challenge. And then finally, how can we move away from, at one end, from a prevention perspective, thinking about populations, and at the treatment end, talk about individualising therapy. So rather than giving all 7 of those medications to an individual, why don't we try and find what's the right medication for the pattern of disease that the individual's got? And so how do we use new markers, whether it's genetics, blood tests, whatever, to personalise the way that we treat heart disease? So I wanted to finish off by telling you about a really exciting project that we are now embarking on in Victoria. The state government of Victoria, in partnership with Monash University and Monash Health, are building the Victorian Heart Hospital. It is Australia's first and only standalone heart hospital. It will be on the university campus. I have come here to build this because I think it is such an exciting project. The idea will be that it will provide world-class healthcare. It will locate research and teaching in the building where the patients are. It will be patient-focused, and it will be about developing more innovative models of healthcare and be able to not only bring research but also kind of interaction with industry all into one building. It has a research focus. It will have an education focus. There'll be a whole range of enterprising models. As you can see on the right, we've talked about things like clinical trials. We've talked about travel medicine. For example, it will be patient-centred. Everything will be embedded in the one building in a much more integrated fashion than what we typically do, where we have research and teaching off to the side from where the patients and the clinical practice is. This is what it looks like from the front. From the front, we're about to dig a really big hole in the ground in the next few days. And embedded within it, we're going to build an institute. So we're not only going to have a Victorian Heart Hospital, but we're going to have a Victorian Heart Institute. And that institute is going to play a research role, and it's going to play a teaching role, and it's going to do it in two capacities. One, it's going to do it directly in the building. So there's dedicated research and teaching space in the hospital. We're going to take the research and the teaching to the bedside where the patients are. But then what we're going to do is we're going to create this whole virtual world for the institute that brings in everybody throughout the university, whether you're in the Faculty of IT, whether you're in the Faculty of Engineering, whether you're in Monash University, Malaysia. And we're going to see how can we really do really significant, big things moving forward to see how we can grow capacity and improve outcomes from a heart disease perspective. As I said, this gives you some context for where the heart hospital will sit on the university campus, and that's been done with a clear motivation in mind. It's about drawing the entire community in to build something that has never been done before in the Southern Hemisphere. And on that note, I'm going to finish with the very last slide. Now, when the statin trials happened during the 1990s, and they showed that lowering cholesterol lowered the risk of heart attack and stroke, two individuals, Michael Brown and Joseph Goldstein, they had won the Nobel Prize for understanding cholesterol metabolism, and that led to the development of the statins. And they wrote an editorial in the journal Science in 1996, and it was titled "Heart Attacks Gone with the Century." And they opined that now that we had effective approaches to treating patients, that by 2000, by the end of the 20th century, that we'd eradicate heart attacks. We didn't quite get there, but there is no reason why we can't continue to be aspirational and eradicate heart disease by the end of the 21st century. It's going to take a global input to do that. I thank you for your attention.
Thank you, Professor Nicholls. So we shall proceed to the Q&A session. I would like to invite Professor Shah Yassin to moderate the Q&A session.
Who would like to start? Got a question? Yes, please. Yes, a little bit. So there's a mic coming behind you.
Good evening. Thank you for your speech. It's quite scary, but I think I can still sleep, I guess. But anyway, I would like to ask a question regarding how certain patients might react about heart attacks. So imagine you're having a patient in his 50s and he's just suffered a heart attack thinking his days are not really that good anymore. It's like he feels like he's going to die soon. Even though he goes through proper treatment and he's better now, but people are worried. So he comes to you and he says that, I heard from my neighbors, whoever, like, I have this homeopathic medicines to be used to treat my heart disease. You know, should I use it like so that this kind of thing won't happen once and for all? So that's one thing. Or he might go to Amazon and buy like this CRISPR toolkit and say, I heard that genes like affecting my heart, so why not I just like tamper with it so it doesn't happen again? Or he might say that, should I use generic medicines so this won't happen? And based on those three scenarios, what is your advice?
So I would say that while I see patients with heart attacks every day, the patient doesn't. So the patient comes in, has a heart attack, and they have a lot, which they survive, They get a lot of information within a few days and then they go home. And the scenario you described is what we do encounter all the time. People come back and they have questions. They didn't get a chance to ask questions while in the hospital, or there was so much information, they get home and it's hard to put that all together. And you're doing that all at the same time as you're dealing with the fact that I just had a heart attack. And we understand that while we provide the best advice we can based on evidence, that patients will often seek opinion elsewhere, whether it's Google, whether it's the media, whether it's the neighbour, whether it's a relative. Not all of that advice is necessarily correct, but we do have to manage longer-term treatment of our patients in the context that they get that information from elsewhere. So I tend to have conversations with my patients about what's happened, what we do know, i.e. we know what your risk is, and we know from our perspective what will reduce your risk, and that's why you're on the medications you're on, and that a lot of these other things don't have that evidence base, but to try and understand what it is that the patient is wanting to do and why they're wanting to do that becomes important. And then to try and understand the cultural environment in which that patient lives may be very different to the cultural environment I live in. So it involves a lot of discussion, but you have to have an open mind to the reality that patients are going to get information from a lot of sources.
Yes, please, here. Or down.
Okay, Doctor, Prof, those who are on statin, it seems advisable to use the supplement called coenzyme Q10. But the nephrologist article says those who are exposed to supplement can injure the kidney. What is your comment on that? And the second question, other than for the sick sinus syndrome, other than the ending in pacemaker, is there any medicine or supplement or whatever it is?
So we know that statins can certainly be associated with muscle aches and pains. For many patients, that's tolerable, but for some people it's not, and patients will come off that. Coenzyme Q, in theory, should help, although the evidence for it is not particularly great. I have many patients who I try to get onto effective doses of statins who have had muscle side effects, and in some individuals where they pay for the coenzyme Q, we'll do that, but I'll say to the patient that they're doing that without any evidence that that necessarily makes a big difference. Sick sinus syndrome we didn't talk about. That's where part of the normal electrical activity doesn't really generate the pulses as effectively as it should. In some individuals that gets to a point where their heart rate is chronically very low and causes symptoms, and they may need pacemakers. There are no medications in between. So we tend to watch individuals with sick sinus. Many never get a pacemaker, but some ultimately do.
Gentleman here.
Steve, the amount of potential disease you can pick up through a blood analysis seems to be increasing all the time. Is there any type of test or anything that you can pick up through a blood analysis that can be predictive in case of heart problem? That's the first question.
Yeah, so I think that, certainly cholesterol, sugar, inflammation markers individually and in combination give us some sense for that. In parallel, I think imaging is showing us a lot more. I didn't talk about imaging at all tonight, but there are a range of different imaging tests which will now show you how much plaque there is. We probably haven't quite worked out exactly the most effective way to use imaging, but I think, again, that will be kind of the next wave of trials to try and inform clinical practice on how best to use those tests.
So when there is a blood test, can you, is there any indicator that say, well, you should now have, say, angiogram or something?
No, not at this point in time. And in fact, I think it's become increasingly clear that if you're having a heart attack, you need to go to hospital.
Right.
If you're just having some chest pain when you go for a walk and it stops, and you have to be assessed, those individuals may have a stress test and they may have an angiogram. It often depends on how much they're having in terms of symptoms. But the idea of taking somebody for an angiogram who has no symptoms, doing an angiogram, we're not doing that at the moment.
Okay. Second question, I think you've got something to do with the APAC Cardiometabolic Consortium. Now, what is that, and how is that different from what you may have in America or in China or wherever else?
Yeah, so what we've done is we've formed a small group of academic physicians in the cardiometabolic space in Asia Pacific. We've met 3 or 4 times. In fact, we're meeting on Saturday in Singapore. And the idea is, how do we build a much bigger community and focus on how can we bring more research to the region? How can we complement the education initiatives that are going on both for healthcare professionals, but then beyond that, patients in the community. So that's early days in terms of building something. So I'm glad you mentioned it, and hopefully in years to come that will be something which will be hosting its own events in places like this.
How is that funded, by the way? How is it funded and
Yeah.
who's sitting on it?
Yeah, it's got a little bit of support by one industry partner at the moment, and I think that our idea would be that it would have support from a number of different kind of avenues rather than be kind of one. I was one of the founding kind of partners of that, and you know, we're just building that to see what platforms we can create to have a kind of more cohesive research and clinical community across Asia Pacific.
So it's a new initiative, effectively.
It's a new initiative.
Yeah, good evening, Professor. Thank you very much. My question to you is, preventive method of heart attack is either by angiogram or by bypass. How many percentage of the blockage you need to go for angiogram, and how many percentage of blockage that you need to go bypass?
Yeah.
My
So-
second question,
No.
My second question is, how long is the lifespan of a stent if you have to go for endoscopy? Is there a lifespan for a stent?
Yeah, so maybe I'll work backwards. So when we put stents in, we're basically putting a bit of metal inside the artery, and what we really need the artery to do is grow its normal lining over the stent. And it will do that over the course of kind of weeks and months. If a stent's going to cause a problem, it'll happen fairly quickly. It'll either clot off in a matter of days or weeks, or it will develop abnormal thickening in a matter of months. If you kind of get 6 months down the track and you're getting more symptoms, often it's a narrowing elsewhere as opposed to the stent. I would say that we use stenting and bypass to treat the disease, not to prevent the disease. We use lifestyle, statins, blood pressure medications, all of those things to prevent the disease. We do angiograms on people when they have symptoms. If somebody has a heart attack, in many hospitals now, they'll fairly quickly, either immediately or within the first day or two, have an angiogram. If it's the non-heart attack setting, then if somebody's got symptoms that can't be controlled and there are supporting bits of evidence to suggest that they might have a severe narrowing, then we would do an angiogram. And what we would typically do is that if you've got a blockage in an artery more than 70%, we would try to stent it. If you have blockages in lots of arteries, then it may be that it's too difficult to stent or put 2 stents in, and that's when we start to think of things like bypass operations. So if you've got what we call single vessel disease, you often get a stent. If you've got multi-vessel, 3-vessel disease, then that's the patients who will get bypass operation, and particular patients with diabetes, because we know that they've got a diffuse form of disease, and so they're more likely to have a surgical option.
I have some comments to make about how we can prevent heart disease. Actually, there's a very good book to read. It's called Why Animals Do Not Die of Heart Attack by Dr. Red Matthias. And this is a very good book. It talks about the direct cause, not contributing factors, not lifestyle, not diet or obesity. It's actually lack of vitamin C, which is one of the important components for the formation of collagen, which keeps the heart, the artery blood vessel flexible and stretchable. And I have seen that marathon runners, you know, they are actually very active. They exercise a lot and yet they die of heart attack at the last maybe 100 meters or 50 meters because they were rushing. I mean, they were trying to get some extra point for, you know, and this. So, so my comment is that to prevent heart attack is actually not a good solution because the pharmaceutical industry will not make money from doing all the heart transplant and you know, angioplasty and all those things. You see.
So I say to people, if the causes of heart disease are A to Z, we know A to F. We've got a long way to go. I think we've highlighted tonight some treatable forms, factors that are involved. I've touched on a number of other factors that I think probably do promote heart disease, stress, pollution, which we've barely scratched the surface. And there'll be others which we don't know at all. So I think we've, you know, as I said, we've had a lot of wins, but we've still got a long way to go. And given the fact that this is a common cause of death, hospitalisation, it still suggests we've got a lot of work to go. You asked the question, how long will a bypass last? We're pretty confident now with good surgical technique that, you know, bypasses should last 15 to 20 years in most patients. So, you know, if you're in your 60s and having a bypass operation, in general, we're hoping that should see you through.
Hi, Prof. The FDA is saying that cholesterol is not a threat to the heart disease, and that the pharmaceutical company are making us dry. What do you say about that?
Well, the FDA, I think the FDA do think cholesterol is important. I think we understand that cholesterol is important from looking at large populations. Show us the higher your cholesterol level, the higher the risk of having heart disease. The genetics for cholesterol are very clear that cholesterol plays a role in heart disease. And the clinical trials consistently show, with a range of different therapies, not just statins, that if you add a medication that lowers cholesterol, patients are less likely to have a clinical event. So that data is very, very clear. Does it mean that we should give everybody in the community a cholesterol-lowering medication? Not at all. What we need to do is we need to target the medications to the highest risk patients. Right? That's where we think the biggest bang for the buck in terms of treating them and getting an effective response to those therapies is. Individuals who are at a much lower risk of heart disease, even if their cholesterol's a little high, they don't necessarily require medication. And so it comes back to this concept I finished with, that idea of personalising the way that we kind of prevent and treat the disease.
Yes.
Can I just ask you to expand on the link between inflammation and heart disease? Are you saying the immune system is involved?
So we now understand, if you kind of look at the pathology of the disease, that some of the very earliest events that occur in the blood vessels involve immune and inflammatory cells. And they get into the wall of the artery, and then it all kind of gets a little out of control. And we know that in a more advanced form of the disease, that those same cells, both inside the walls of the vessel and potentially outside, can make that kind of cold plaque become hot. And the hot plaque then is more likely to cause a heart attack. So the pathology tells us the inflammation is important. The second thing that tells us important is that there are, coming back to the question that was asked down the front earlier, there are blood tests of inflammation markers that we know that if those inflammation markers are higher, then you're also at a higher risk of having a heart attack. And then the third line of evidence is that we now have clinical trials of 2 different agents targeting inflammation in 2 very different types of ways that have been shown to reduce the risk of heart attack in high-risk patients with high blood levels of inflammation markers. So I think the inflammation story is real, and how it will now move forward in terms of new tests and new therapies we wait and see. But if you put all the pharmaceutical stuff aside and think about all the lifestyle things we've talked about, weight loss, smoking cessation, reducing pollution, reducing psychosocial stress, will all lower inflammation markers as well. So I think the inflammation story can play right across the kind of lifestyle and the pharmaceutical side of what we're looking at.
I have a question on arrhythmia. Can arrhythmia exist without any underlying causes, and can pressure be the only cause of arrhythmia? And how is the person die early or what?
So arrhythmia.
Are you asking what is the causes of arrhythmias?
Can there be no any specific causes for arrhythmia? And can pressure be the only cause?
Yeah, so we know that people who've got heart disease of any form, whether it's heart attacks, a large heart, valvular disease, have a higher risk of arrhythmia, whether it's in the atria, the filling chambers, or the ventricles, the pumping chambers. But we also know that there are individuals who can have those rhythm problems without any obvious cause. And blood pressure by itself can contribute, absolutely. The treatment for those individuals is no different.
My name is Tan. Now, in Australia, there's a very high consumption of alcohol. You didn't mention about alcohol, and in fact, in Australia, it's a culture of having a party and must be drunk so they really enjoy a party, you know. And the other thing is the drug addicts. This is a new system coming in. I'm not talking about the pharmaceutical drug. I mean the hardcore drugs that's coming overseas. Can you comment on these two issues? Thank you.
So alcohol is a complicated story. There's some data to suggest that alcohol in moderation might potentially be protective. But we also know that getting it out of moderation is going to associate with more weight, higher levels of triglycerides. It can have a direct toxic effect on the heart muscle itself. So the alcohol story becomes a very difficult one, so the moderation story becomes critical. I'm not going to quite so many of the parties you're describing. On the drug side, you're absolutely right. We know that a number of illicit drugs will have cardiac effects. Cocaine will cause the arteries to spasm, can actually look like a patient's having a heart attack. We've certainly all had patients who have looked like they've had a blood clot blocking an artery, taken them to the cath lab, and the artery was basically open and it was probably cocaine. We have a big problem with kind of methamphetamines in Australia. That's going to have some risk in terms of heart disease risk as well. And so I think the point is a really important one. And it really comes back to that notion. If we think the causes of heart disease are A to Z, we're still learning the alphabet.
Perhaps the last question. Yeah, down there.
Good evening. My name is Un, and I'd just like to relate the story and ask my question at the end. This is the story of somebody I know. He's a marathon runner. When he took his first stress test at the age of 40, he found that he had a problem because he had ST depression, stage 3 of the stress test. So they put him through an angiogram, and they found a 40 to 50% stenosis in left anterior descending. And doctor says, no intervention needed. You have a healthy lifestyle, so keep on running. I'll give you cardioprin, you see. So that went on for 20 years. And in the 20th year, during a run, he nearly fainted. So he went in for an angiogram, and they found that that stenosis is now 70 to 80%,
So they put in a stent, okay, in the LED. And after that, the doctor says, oh, you'll be okay from now on. Your stress test should be normal. But when you put him on a stress test about 3 months after the angioplasty, after the put the stent in, they found that he still had a ST depression third stage. Is that normal? Thank you.
Yeah, well, I think there's a number of interesting points in the story you've told. I mean, so first of all, it highlights a couple of important points. One, it highlights the natural history of the disease. So the 40% doesn't necessarily always stay 40%, right? Secondly, it highlights and reiterates the point I've made a number of times, which is that we don't have all the answers for the causes of heart disease. So, you know what, there are always going to be people who don't have the conventional risk factors who may have heart disease. Now, the majority of my patients are not the marathon runner with no risk factors. They're the non-marathon running, smoking, diabetes, overweight patients, but I absolutely have the other patients, and they're there looking at me going, why am I here? Why do I have a heart attack? And so we've still got to kind of work all of that out. The third thing I'd say would be that we don't always get it right in terms of actually connecting what we see on the angiogram to the symptoms or the objective findings on a stress test. So when we get somebody into the cath lab and we do that angiogram and we see a tight blockage, we think, okay, well, this is a person who's had symptoms. This is a person who's had an abnormal response to a stress test, and I now see a 70% narrowing here. So I'll stent it. Well, that might not have actually caused the changes we saw on the stress test. And the final comment I'd make is that the 40% leaving it alone was absolutely the right thing to do. So you can move blood down a blood vessel completely normally with actually a reasonably tight narrowing. It's only when those narrowings become probably more than about 70% that we do anything about it, because the benefits of opening up a 50% narrowing begin to be outweighed by the risks of having the procedure. Whereas if you've got a 90% narrowing, we know that the benefits outweigh the risks. And so it's all about bringing it back to the patient, right? I talked about that a bit in my talk, and that is going to become an increasing focus on the way that we deliver our healthcare. Patient needs to make informed decisions, so we need to be able to provide the best information we can. And a lot of the questions we've heard here tonight are really about that, whether it's the patient who's gone home and looked up Google or the neighbours told them you should take this or that, to these types of things. It's really about trying to find the time to talk to your patient, to explain the situation in a way that they can receive that information and process it. So it may be that 5 different patients, I have to provide a slightly different story to all 5 of them because they're going to process the information differently.
It's not popular anymore.
What is that again?
The resorbing stent.
The dissolving stent is not popular anymore. Why
Well,
is that?
They're expensive and they haven't necessarily been shown to be any better than the other ones. I'm never worried about putting a stent in a patient and leaving it there. The artery grows that lining of tissue over it. And I say to my patients, we're going to put this little bit of scaffold. It's going to keep the artery open. And apart from the early changes I talked about earlier, it's not going to cause any long-term problems. So I don't need it to dissolve. It's just going to do its job, and that's fine. Not widespread, no.
Okay, I think it's time to wrap up. I think, we have had a very good session. Can I get you to thank our speaker, Professor Nicholls? We may have a small little...
a token of appreciation
Token
to
of
Professor
appreciation.
Nicholls, if Professor Shah Yassin could.
Thank you.